Hello, I'm Matthew Weinstock with Hospitals and Health Networks. As change sweeps through the healthcare system, perhaps no segment is more at the crossroads than rural hospitals. Facing demographic, geographic, and financial constraints, rural hospital leaders face some daunting challenges. For starters, where do their institutions fit in a market that's moving towards an integrated, affiliated model? Joining me to talk about some of these risks is Clint MacKinney, Deputy Director and Assistant Professor at the University of Iowa's College of Public Health. Clint, thanks for being with me today.
You're welcome, Matt.
So Clint, could you talk about some of the risks that are facing rural hospitals right now?
Well, fundamentally, Matt, one of the things that's going to be happening over the next 5 years around risk for rural hospitals is we're going to see a transfer of various types of risk between the payers, like Blue Cross Blue Shield and Medicare, to providers, hospitals, and doctors. Now, we've talked about this, that there are 4 different kinds of risks. There's randomness, chance. You can't do anything about that. Then there's insurance risk. Now, this is what insurance companies do very, very well, and I don't think we as providers are going to be that good in that. There's also political risk, where our advocacy groups can help us. But then there's clinical risk, and that's where I think we can really excel.
How so?
Well, clinical risk means variation in the care that we provide, variation in what pharmaceuticals we choose, what technologies we choose, how good we are as diagnosticians, and all of that impacts not only quality of care, but how efficiently we use resources. So, if we want to reduce that risk, we'll excel in that clinical risk realm, and we as hospitals will actually be that much more successful.
So you're a practicing physician in an ED. How does that play out in terms of your day-to-day practice?
Well, physicians, probably there's no better example of where there's variation and thus risk for doing things well and doing things not so well, as in when we look at physician practices. And I argue that care for patients should vary by the patient, by the individual patient, but it shouldn't really vary by the doctor or by the day of the week or the time of day. So if we can develop our skills so we're getting the right care to the right patient at the right time and consistently, that's going to reduce the variation in care and actually improve it, I believe, as well.
Do you think that rurals are positioned well enough to be able to make that change, to reduce some of that variation?
Well, I think like urban systems, rural has got a ways to go. For example, how do we get the data to be able to help us whether one physician is doing things one way and another physician is doing it differently? And then how do we compare that and how do we learn from one another? Those are skills and data management techniques that a lot of us still need to develop. And I think we need to develop it quickly so we can operate in this new era that you were talking about.
So we're seeing a lot of creations of accountable care organizations, whether it's through the CMS accountable care definition, or even in the private sector through insurers or providers creating their own organizations.
Yes.
What role do you think rurals play in that environment, and how do they position themselves to be attractive to an accountable care network?
Well, accountable care networks are interested in those providers that provide value. And again, high quality, great patient experiences, and low cost. So we in rural are pretty nimble, and we probably can change our processes to improve that quality for those things that we do. We already provide really great experiences for patients. Our patient satisfaction numbers are really quite high compared to rural to urban. And cost, we need better data yet, but I think all of us can use resources more efficiently so we start to reduce that cost. So I'm hopeful that rural really steps up to that challenge and it says that the way we're going to deliver value is we are going to aggressively improve our quality, we're going to aggressively improve the patient experience that our patients have, and we're going to be very mindful of public resources and use them wisely.
And lastly, Clint, what do you think the future is for independent rural hospitals, whether it's a critical access or a tweener? Are they going to be able to go it alone? Are they going to have to find some partners? Are they going to be merged into larger organizations?
Independence is not a mission statement. It's not an end game. But nonetheless, we feel viscerally about its importance sometime in rural. I think independence, in its broadest sense of the word, is really an archaic concept in medicine. We need to work with one another to provide the best care for our patients and our communities. Now, when I say independence is an archaic concept, I'm not implying that we need to be owned by anyone, but we need to be affiliated clinically so we can provide care across the continuum of care that we can't do alone as physicians or hospitals. We need to consider care around rehabilitation, around prevention, around public health, around palliative care, around hospice care. We can't do it alone. So the faster that we can learn to develop these affiliations and collaborations that help us care for patients from cradle to grave, we're going to be much better off, and so will our rural communities.
Great. Well, Clint, I appreciate your time today.
Thank you.
And I'm Matthew Weinstock, reporting for H&H Daily. Thanks for tuning in.